Hello everyone. So we are going to study Barrett esophagus. Barrett esophagus, it is basically a complication of chronic gastroesophageal reflux disease, which is characterized by intestinal metaplasia within the esophageal squamous mucosa. So Barrett esophagus is intestinal metaplasia within the esophageal squamous mucosa, that is, squamous epithelium is replaced by intestinal lining epithelium due to chronic gastroesophageal reflux disease. The incidence of Barrett esophagus is rising and it is estimated to occur in as many as 10% of individuals with symptomatic GERD. It is most common in white males and typically presents between 40 and 60 years of age. The greatest concern in Barrett esophagus is that it confers an increased risk of esophageal adenocarcinoma. So Barrett esophagus is basically a precursor to esophageal adenocarcinoma. So Barrett esophagus is a pre-malignant condition. Keeping with this in view, epithelial dysplasia considered to be a pre-invasive lesion and it is detected in 0.2 to 2% of persons with Barrett esophagus. So epithelial dysplasia associated with Barrett esophagus is seen in 0.2 to 2% of cases, and this dysplasia is pre-invasive lesion. Although the vast majority of esophageal adenocarcinomas are associated with Barrett esophagus, it is important to remember that most individuals with Barrett esophagus do not develop esophageal tumors. Though Barrett esophagus is associated with esophageal adenocarcinoma, but not always it ends into adenocarcinoma. Barrett esophagus, it can be recognized as one or several tongues or patches of red velvety mucosa extending upward from the gastroesophageal junction. This metaplastic mucosa alternates with residual smooth pale squamous esophageal mucosa and interfaces with the light brown color gastric mucosa. Alternate pale and light brown color mucosa. The sensitivity of Barrett esophagus detection, it has been increased by high resolution endoscopes. This has led to subclassification of Barrett esophagus as long segment or short segment Barrett esophagus. The long segment esophagus is when 3 cm or more of the esophagus is involved. When 3 cm or more of esophagus squamous epithelium is replaced by intestinal epithelium, then it is long segment. Short segment when less than 3 cm of esophagus is involved. Diagnosis of Barrett esophagus, it requires both endoscopic evidence of abnormal mucosa above the GI-GE junction and histologically documented intestinal metaplasia. So, this microphotograph is showing here you are seeing the squamous epithelium lining, which is replaced by the intestinal lining. Goblet cells, these are goblet cells. Goblet cells which have distinct mucous vacuoles that stain pale blue by He and impart the shape of wine goblet to the remaining cytoplasm. define intestinal metaplasia, and they are necessary for diagnosis of Barrett esophagus. These goblet cells, they are necessary for diagnosing Barrett esophagus. The requirement for intestinal metaplasia reflects that the fact that this feature correlates with the neoplastic risk. So, metaplasia is risk towards neoplasia. Metaplasia will change into dysplasia, then into carcinoma. Foveolar mucus cells, which do not have distinct mucus vacuoles, are insignificant for diagnosis. The requirement for an endoscopic abnormality helps to prevent misdiagnosis if metaplastic goblet cells within the cardia are included in the biopsy. So, after noting the intestinal metaplasia with goblet cells, we will decide it is Barrett esophagus, and we have to mention the presence of whether dysplasia is present or absent. So, when dysplasia is present, it is classified as low grade or high grade. Increased epithelial proliferation, often with atypical mitosis. Nuclear hyperchromasia and stratification. We are seeing here stratification, hyperchromatic nuclei, irregular clumped chromatin, increased nuclear to cytoplasmic ratio, and failure of epithelial cells to mature as they migrate to the esophageal surface are present in both grades of dysplasia. So, when we will say that dysplasia is present or not, when there is epithelial proliferation with presence of atypical mitosis, hyperchromasia, stratification, high NC ratio, clump chromatin. In addition, the gland architecture is frequently abnormal and is characterized by budding. We are seeing budding in glands and cellular crowding. High-grade dysplasia exhibits more severe cytologic and architectural changes. Intramucosal carcinoma is characterized by invasion of the neoplastic epithelial cells into the lamina propria. So, intramucosal carcinoma, when invasion of neoplastic epithelium is into the lamina propria. So, patients with Barrett esophagus, they present with symptoms of GERD, gastroesophageal reflux disease. Periodic endoscopy with biopsy for detection of dysplasia has an important role. Uncertainties about the potential of dysplasia to regress either spontaneously or in response to therapy complicate the clinical decision when dysplasia is identified. In contrast, the intramucosal carcinoma requires therapeutic intervention. Treatment options are surgical resection or esophagectomy, as well as newer modalities like photodynamic therapies, laser ablation, and endoscopic mucosectomy. Multifocal high-grade dysplasia, which carries a significant risk of permission to intramucosal or invasive carcinoma, is treated similarly to the intramucosal carcinoma. Esophageal varices. Instead of returning directly to the heart, the venous blood from the GI tract is delivered to the liver via the portal vein before entering or reaching the inferior vena cava. This circulatory pattern is responsible for first pass effect, in which drugs and other materials, they are absorbed in the intestine. They are processed by the liver before entering the systemic circulation. So, diseases that impede this flow, that will cause portal hypertension and can lead to development of esophageal varices. And important cause of esophageal bleeding. Genesis of esophageal varices. Portal hypertension will result in development of collateral channels at sites where portal and cable systems communicate. So there is formation of collateral channels. Although these collateral veins allow some drainage to occur, they lead to development of congested subepithelial and submucosal venous plexus within the distal esophagus. So, due to collateral channels, there are congested subepithelial and submucosal venous plexus within the distal end of esophagus. These vessels are termed as varices. They develop in 90% of cirrhotic patients, most commonly in association with alcoholic liver disease. The morphology of esophageal varices. This microphotograph, this is the angiogram showing tortuous blood vessels, tortuous esophageal varices. Then these are collapsed varices. They are present in postmortem specimen corresponding to the angiogram. And this histomorphology shows polypoidal areas. It represents the variceal hemorrhage, this dilated varice. The dilated esophageal varice with intact squamous mucosa. Varices are often asymptomatic, but when they rupture, they cause massive hematemesis.